Thank you. I would like to start the presentation by thanking HL7 community for having an opportunity to showcase my product here, Collaborative Notes. In brief, my background includes I'm a physician working in an inpatient healthcare setting from last 10 years and a couple of years in utilization management. And we have this company called Collaborative Notes, and this is a startup based out of Massachusetts, and it has a development center in southern India. That's where the most of the hits are coming from. That the previous map Graham was showing. So, the idea for this application sparked based on my experience and also based on the observations in my clinical practice. But the genesis of the idea from the application into the app itself happened with the FHIR protocol. So I wanted to show the problem we are trying to solve. So in the typical healthcare setting day for a hospitalist, in the morning time, we have a call from the administration saying that when we have 15 boarders in the emergency room, we need to discharge them quickly. And then we have a utilization manager saying that, hey, why this patient is inpatient? Why can't it be the observation? And the case manager is calling us saying that, yes, why don't we change the antibiotic from which can be given instead of 3 times a day to 1 time a day so that we can discharge the patient quickly with one visiting nursing service. So there is so many people involved in the care nowadays. It's become very complex and complicated. And what we are trying to do, it is like creating an application which will not completely solve this problem, but get a control on the situation and also communicate with the different parties involved in the care. So that's where the FHIR part comes into this one, and all the other tools and everything calls the Collaborative Notes. In combination, this is the Collaborative Notes on FHIR. So, talking briefly about the application itself, it's a native mobile application written for the tablet format, and it can be launched as a smart on FHIR or as a native application. We built multiple the tools to improve the user experience, including the predictive typing and caching and synchronization, etc. Along with those things, and we are also providing the end-to-end encrypted communication tools like a chatting and a video call, so that the physician can be able to talk with the providers, other providers easily. And with those, along with those tools, we are also creating some other tools for the trade kind of thing, for like looking at the medical necessity evaluation, and also coding CDI tools and discharge planners and charge capture, medication reconciliation, etc. These are all built in the native format so that we can have the best user experience. Now I want you to imagine that the doctor going to the patient room with an iPad and sitting next to the patient and getting that medication list from the primary care using the FHIR and kind of doing the reconciliation. At the same time talking with the case manager there from itself and planning for the discharge or whatever it needs to be done after the post-acute care. And so once we are done with that one, the note is generated and then the charge is captured. You're coming out of the room with everything done. So we are able to, with this tool, we believe that the patient will be able, the provider will be able to spend more time with the patient. That increases the patient satisfaction and also the quality of care itself. And how we are using the FHIR in a collaborative notes. So we are taking the different scenarios which we need to develop in an interval phases kind of thing, and we are defining the resources we need to use it in that case, and we are developing them, we are testing them. While we are doing this, then we are constantly in communication with the FHIR community. We're happy. I want to thank the FHIR community at this moment of time for all the support they are giving it. And so whenever we post a question in the Zulip, and we get the answer very quickly, and that's always helpful for the development, and so that we don't have to sit there and kind of watch somebody else coming and saying after months and months. So once we developed that resources, we are publishing implementation guides. We have our own personal registry. Let me take you this one. So this is a personal registry we are creating. And along with the implementation guides we created, which are in the red color, and we are also using other implementation guides for the development of this application. Going back to the presentation, okay. So then, and the app is completely designed over the FHIR models itself, but I cannot show you the whole application here. That's going to take forever. So I picked 3 use cases which I wanted to showcase here. The first case is taking a patient, talking about the patient-controlled data access. The second is the clinical data capture, and third is the document generation using the CCD and FHIR format. Let's imagine the provider is searching for a patient, and once he found the patient, he needs to add the patient to his list, and then the app is going to check for the consent, whether the provider has the access of the data. Before doing that, when the app is going to check whether the consent itself is correct or not, if there is a consent already available. This we are doing it based on the digital signatures created for the different systems integrated in the part of the system. Once that has been done, once we have a valid consent, we are looking at the consent rules and whether it's expired or not, and also whether the user is giving the full access to the patient data. If that is so, we are pulling all the data from different sources and we are showing it to the user. And if there are any exceptions, let's say that the patient doesn't want me to know about the alcohol history he's been having it, we are able to show the notifications in the appropriate screens. For example, the medication screen, we are saying that hey, you don't have access to look at the alcohol-related medications, or in the social history, you cannot see that section. So this is for the reading and looking at the data. At the same time, when you're creating a resource in these exceptions, which the system is going to say that, hey, I'm sorry, but you don't have an access to write the resources. The second thing is looking at the clinical data of a patient, where we are able to look at all the resources, for example, past medical history, all the conditions, and then we will be able to add a new condition. If when talking with the patient, he came with another condition which we forgot to tell before. So that also we are capturing it using the mobile environment. And then the third scenario is while we're collecting all this clinical data, the user will be able to select what he wants to include in the document. Once he selects that, the system is going to build a document bundle based on CCD and FHIR, which we can submit to the document server. From there, we can distribute the data to the patient and also to the primary care doctor who provided the medication list for that patient, which we are trying to take care of. So these are the 3 scenarios which I wanted to show it in the next demo. And this is a mobile platform, so I'm not able to open up a website, so that's why we created a video, and which I wanted to show you in the next screen. CDS. Sorry, the music is over. I'm sorry. So there, actually, the video went a little bit quicker there, but we're able to retrieve a document from the document server, and using the narrative part of the CCDA, we're able to show the human-readable part of the document. And a little bit about the backend, what we are trying to use it. We are using the microservices-based architecture, and the services are, we created multiple services. I don't know how many services we created right now, but they're all been controlled using the Netflix OSS, and the containers are hosted in the AWS platform. And we have 3 layers of the services. This is just meant for the logical sense, or for the easy to describe purpose only. So there we are actually have like front-end services which will support the application, and not just the RESTful services. We're also using the asynchronous methods for the in-app notifications, and also for the also in the middle layer we are using the aggregating the data, and from that one we are planning to use the analytics, including the provider analytics, which we are already in process of developing them, and also the population health analytics, including the quality metrics, which we want to capture it. The third layer is the data ingestion layer, where we are trying to get all the data from different sources, not just from those different sources, along with the Exchange integration. We were planning to do it. So this is the collaborative notes in brief. Thank you for having me here, and if you have any questions before the next speaker comes, I'm more than happy to answer them. Thank you.